Hi, Elliott.
Hello, good to see you again, Jonas.
Good to see. Good to see you. Thank you for accepting this invitation for this interview. And I would like to start asking you to introduce yourself and introduce the study that you have conducted and the way you got in touch with MAPS.
Yeah, I'm happy to do so. My background is actually not in psychiatry, so this area is new for me. Most of my professional work has been in global health, and I lived in Nepal for 7 years in the 80s running a national blindness prevention and control program. And then I came back and did my doctoral work in health policy at Berkeley. And through serendipity, I met somebody who was doing cost effectiveness analysis in global health. And for the next 25 years or so, I've worked on the economics of mainly HIV treatment and prevention, but other global health diseases as well. And so the new focus on the economics of psychedelic assisted therapies came out of a chance meeting that I had with Rick Doblin, who, as you know, is the founder and director of MAPS. I've attended Burning Man in the last 6 years, not this past year, of course, because it didn't happen. But in 2017, I was at a training for people who volunteer at Zendo, which is my volunteer job at Burning Man. That is being with people who are having a difficult experience, usually with psychedelics, not always, but almost always with psychedelics. And so we're trained to just be with them while they're going through what they're going through. Anyway, it was a retraining, and Rick happened to be there, not surprisingly. And I just introduced myself to him. And, you know, he's like a rock star in that situation. Everybody wants his attention. You know, it would have been very easy for him to just say, "Oh, great to meet you, you know, see you later," kind of thing, you know. But he didn't do that. He asked me about myself and about my work, and I mentioned I'm a health economist, and he said, "Oh, we need you." And I said, "Fine, you got me." I'm at a point in my career where I can pick and choose my work. I'm kind of semi-retired. Anyway, so I started working in this area since then, and I'm working on some other projects, but the main psychedelic related project is the one that we now just completed on the cost effectiveness of Mdma for PTSD.
Interesting. So, as far as I know, it's the only study of this kind. Is that correct?
Yes, it is the only study I'm aware of. I'm pretty sure I can say with confidence. It's the first study on the cost effectiveness of a Schedule 1 psychedelic for therapeutic purposes. There is a cost effectiveness analysis of esketamine, to treat depression. That's a little bit different because it's legal. But yeah, so of the classic psychedelics, you could dispute whether MDMA is a classic psychedelic, but anyway, it is the first.
All right. I'm curious to ask you, what data did you use and what are the findings?
Yeah. So the effectiveness data came from the 6 phase 2 trials that MAPS conducted on MDMA-assisted therapy for people with chronic, treatment-resistant, and severe or extreme PTSD. And I want to emphasize that the trials were for people who, first of all, are severely affected by the disorder, and nothing else seems to really work for them. There's a 2019 study that pooled the results from those 6 trials. So because each one of the trials is small and didn't have a lot of statistical power, but you put them together, and we had 105 subjects that we had results from, and those results were extremely encouraging. So that's on the effectiveness side. On the cost side, there's 2 kinds of costs here. One is the cost of the intervention itself. What does it cost to provide the psilocybin assisted therapy. That's one cost. And the other cost is, how does this affect the medical care, cost of the medical care utilization of people with PTSD? Because presumably, if people are getting better, they're consuming less health care. And so there's a possibility that the intervention saves money. The intervention itself costs about $7,600 US, US dollars, which is not exactly cheap, but it's a one-time therapy. And if you're diminishing the cost of a lifetime of both psychiatric and non-psychiatric healthcare utilization, there's a potential to save money. And I want to emphasize, we looked at all costs, not just the psychiatric costs, because PTSD is associated with chronic and expensive healthcare conditions, cardiac conditions and diabetes and so on. So so the cost, the estimates of the cost of the intervention, I'm now returning to the intervention, comes from just, we took what we call in the business a micro-costing approach, which just means that we identified every input, so X number of hours of the therapist's time, and for the pre-sessions, and then Y number of hours for therapists during the active Mdma sessions, and then the post, like just detailing every single thing, and then estimating the cost of those inputs based on what does therapy cost now, what does Medicare. It was all U.S. oriented, so you'll have to forgive me for that. But we did take data from the U.S. So in our country, what does it cost an hour of therapy? What does Medicare reimburse? What does the Veterans Administration reimburse? What do private health insurance companies reimburse? And so we took estimates of those costs from 8 different cities in the United States and took an average. Okay. And so it's kind of like accounting. That part is intellectually, frankly, it's not that interesting, but it's vital to get it right. So we added all of that up. And as I mentioned, it's about $7,600. And then the healthcare cost comes from the published literature on what is spent per year on people who have severe PTSD, extreme PTSD, and then milder cases. And as you would expect, the more severe, the more is spent. So that's where the data come from. And one other thing. So that's all on the cost side. On the effectiveness side, in my business, there's a term we use called utility, which is, it's really just a measure of well-being. And by convention, if you're dead, your utility is 0. And if you're in basically normal health or perfect health, your utility is 1. And everything else is a number in between. And I'm not going to go into details too much for this conversation, where those numbers come from, but there's methods for eliciting what the utility for different health states is. And so there's estimates of what the utility is for extreme PTSD, severe, mild, moderate PTSD. And so with the effectiveness of the intervention is in moving people from more severe to less severe categories of the disease, and having and getting the benefit of that increased well-being that's associated with those less severe disease states. So those are some sort of basic kind of ingredients that go into it.
That's very interesting. So as far as I understand, this kind of information is very useful for insurance company. That's correct?
Well, yes. So, what we wanted to estimate cost effectiveness and cost savings. And I want to just, if I can, just say a little bit more about kind of cost effectiveness theory. Sometimes people confuse that. If you say something is cost effective, they go, oh, it saves money. No, that's not what cost effective means. What it means is that it's good value for the money. It may result in a net cost, but you get lots of benefit for it, so it's a good place to spend money compared with other ways you could spend money in the healthcare system. That's what cost effective is. Cost saving is beyond cost effective. It means not only are you providing clinical benefit, but the payer is saving money, that the intervention is the healthcare savings is greater than the cost of the intervention, so that over time you actually save money. And what we found in this analysis was that is true. That if we ran our model with 1,000 patients, and over 30 years, it would save healthcare payer about $103 million. So to circle back to your question, we are hoping that this paper gets the attention of people who are managing private insurance companies, the Veterans Administration. In the United States, we have such a complicated system, and there's so many payers. In Europe, it's more straightforward. But the point is to bring it to the attention of insurance companies, both private and public, and have them consider including MDMA-based therapy as a benefit for their members once it becomes a legal. Obviously, FDA approval will be needed first, but that's the idea. And so I'm hoping that our paper begins to catalyze a conversation among health insurance managers about, well, maybe we should consider this would be good for our members and could save us money. So yeah, that's the idea.
Thank you very much for explaining this. This was very clear and very interesting. So at this point, I know phase 3 is underway.
Yeah,
and, is expected to be completed something around 2021 or 2022. Is that correct?
Yeah, I'm not sure of the exact timing, and I think with COVID, it's been delayed somewhat. But you're in the right ballpark for sure. Yes.
Do you think this kind of study will be replicated once phase 3 is completed, or the data collected with phase 2 are probably the same of phase 3?
Yeah. So the preliminary data from phase 3 suggests that that the phase 3 results will confirm the very favorable phase 2 results. Maybe even better, we don't know, but it's looking good. And MAPS will want to do a similar analysis from the one to the one that we did for phase 2 for phase 3 for a couple of reasons. First of all, phase 3, it's phase 3. It's the most definitive. And I was actually a little bit concerned that journals might not be that interested in this paper because it's just phase 2. But really, that's a kind of prejudice because we pooled data from 6 trials. So in effect, it was a large trial. Anyway, I'm digressing a little bit. But, the phase 3 trials are the most definitive. And the inclusion criteria for phase 3 are a little bit relaxed compared to phase 2. So it includes people with less severe and less chronic forms of the disorder. So it's a broader segment of the people who are suffering from PTSD. Well, I will say that one limitation of our current paper is that it focuses on the most extreme end of the spectrum. And there's good reasons why MAPS chose to do that, which I think you can understand. But we cannot say, we have demonstrated that this is cost effective for people with PTSD in general. It may be, but we haven't demonstrated that yet. We're confined. Yeah. So the phase 2 studies were confined to the more severe forms of the disease. Yeah.
Well, thank you for pointing that out. I'm curious to ask you, was it easy to find a journal interested in publishing? Did you submit the study to different journals? How was the process?
Yeah. We aimed high. We started with, JAMA, the Journal of the American Medical Association, and they turned us down instantly. and then Lancet turned us down, and then said, but we sent it to Lancet Psychiatry, the point is that 3 or 4 journals, I think it was 4 journals, turned us down at the editorial level. I mean, it wasn't, nobody reviewed it and said, it's not a good paper, we can't publish it. It was at the editorial level, and if you know how this works, they don't tell you why. It could be like, hey, we're just preoccupied with COVID right now, or for whatever reason, the subject matter didn't interest them. I don't know. It's a mystery, and that's just part of the reality of life when you're trying to publish in medical journals. And so I think PLOS One was the 4th journal. Fortunately, we were turned down very fast, usually within 24 hours. They would say we can't use it.
Time.
Yeah, so it didn't cause too much delay. Yeah.
Interesting. And I'm curious to ask you, what has been your collaboration with the other authors of the study?
Yeah, so I had 3 co-authors. The second author is a dear friend and longtime collaborator of mine, James G. Kahn at University of California, San Francisco. And he's the one who introduced me to cost effectiveness analysis. So I mentioned I was in Nepal. I came back, I did my doctoral degree, and I was looking for a job, and I won't go into too much detail here, but anyway, I ran into him and we just kind of hit it off. And he had a little bit of money for a little project it was evaluating a very small HIV project in Los Angeles. And so we did that, and one thing led to another, and 25 years later, we're still working together, both on global health projects. And then I brought him into the psychedelic science because he was intrigued, could see this is like new ground. And so it was wonderful to have a longtime friend and collaborator. And then the other 2 authors are from MAPS, including Rick Doblin, who of course we know who he is, and Bera has been working with me on my MAPS related work from the beginning. So she's another co-author. So I think it was appropriate to have the MAPS people. I will say that Jim and I work pro bono. We just wanted to do this, and we're at a time in our lives where we could do that. And it has the added value of, it's no perceived conflict of interest. Yeah.
Makes sense. So imagining, for example, in the future, an insurance company wanting to analyze or replicate the study, is this something that there are consulting agencies specialized in this kind of studies that analyze the data and come to their own conclusions?
Yeah, absolutely. So anybody can look at the, let's see, how to say this accurately. People can get the effectiveness data from MAPS. They have to apply for it. And, you have to be a bona fide researcher. And so there's various conditions, but basically it's part of MAPS's policy to make the data available to people who are serious and well-qualified researchers. So that's one part of it. And then on the cost side, the costs come from the published literature, which is, well referenced. So it's pretty transparent, how we did things. Other researchers can duplicate our efforts. And then, if things are moving fast, so the phase 3 results will be released soon. And I think it would be more interesting to analyze the phase 3 data than to recapitulate the phase 2, but whatever. There's enough money and frankly, sort of risk, I suppose, associated with if an insurance company provides a psychedelic-based therapy. There is, let's face it, there's some residual stigma attached to it, and they want to know that it's safe and effective, and they should be concerned about that. But
right.
Again, the evidence is, I mean, it just keeps piling up on both safety and effectiveness. It's just hard to ignore how encouraging it is at this point.
Absolutely. Yeah. So let's imagine best case scenario in 10 years. Do you think insurance company could include this kind of treatment?
I do. I mean, there is so much interest in it and so much demand. And there's also support from sort of unexpected quarters. So, you know, you would think that people on the political left, let's say, might be more interested in this because psychedelics have their root in the counterculture in the United States. I'm speaking about the United States here. And that more conservative people might be put off by it. And that may be true very broadly, but quite a bit of funding for psychedelic research has come from very conservative groups, but who also have a libertarian orientation and who are patriotic. They want to do something for veterans who are, you know, suffering in very large numbers from this. So what I'm saying here is there's sort of a confluence of interests coming from different directions. And then, you know, if you're running an insurance company and you see an opportunity to provide a good treatment and save money, the logic could be pretty compelling.
Yeah.
So, yeah, no, I am optimistic. I mean, I think this is where things are going, and it'll take some time, but we'll get there. Yeah.
And I'm curious to ask you something about what could be a situation in Europe in the future. So let's imagine 5-10 years from now, Mdma, psychedelic therapy, it's approved also in Europe. As you know, the healthcare system in Europe, it's a little bit different. The insurance company are less involved than here. So Do you think that could be more difficult in Europe to integrate, like, could this study be helpful also for public authorities in terms of saving money, in this case from the state?
Yeah. Well, I have less knowledge of the healthcare systems in the various European countries, except the general knowledge that your system is relatively sane compared with our just fractured, crazy system. And I do know that some European countries, I know this is true of the UK, the equivalent, so the European Medical Agency, actually, they take cost effectiveness into account. They won't approve a new intervention unless it's cost effective. You're probably aware of that. That's the FDA doesn't care about it. They're just concerned about efficacy and safety in the US. But the European Medical Agency does the need to demonstrate good value for the money. And so the need to do an analysis, you know, like the one that I did, doesn't have to be identical, of course, but as answering the same basic question in Europe would be very important. So presumably the effectiveness is pretty much the same among Americans or Europeans, let's just say, but the cost would be very different. So both the cost of the intervention would be lower, and also because medical care in general costs less in Europe, the savings would therefore be lower. And how the net result comes out, I don't know. If I had to place it there, yeah.
That would be something interesting to research.
Yeah.
It could be a whole study by itself.
Absolutely. Yeah. Yeah. No, I mean, I think if we're going to make progress in Europe, and we are. I mean, there are MAPS associated teams in Europe who are working on this. I think the cost effectiveness part will be just as important for European countries. Yeah, absolutely.
Thank you so much. This was very interesting. So for our audience, if people want to dig deeper into the study, where they can find it?
Oh, well, if you go to PLOS One, it is publicly available. You can download the PDF free of charge. And maybe the most efficient way would be if you put a link on your website, and then literally like two clicks away, and you've got the PDF.
Perfect.
So, yeah.
We will do that. Thank you very much.
Good.
All right. I think we're getting closer to the end of our interview. Is there any other final comments you would like to share? How long did it take to make the research?
Oh my gosh, it took a long time. It took
months, years?
Well, it took me about a year and a half. Now, I was working on many other things too. But this was a new area for me. So I had a lot to learn. I haven't modeled a disease like PTSD. So it took some time. It took me longer than most of the studies I worked on. From now on, it'll get faster. No, it was an effort. I think I would like to say I've published, I don't know, something like 70 peer-reviewed cost-effectiveness analyses, something like that. This is the most robust findings I've ever been involved in creating. That is to say, the model has a lot of uncertainty in it. All cost-effectiveness analyses do. There's uncertainty about the effectiveness, there's uncertainty about the cost, various sources of uncertainty. It doesn't matter. You can throw anything at this analysis and it won't change the qualitative result, which is to say, this is highly cost-effective and almost certainly cost-saving. In other words, you can take issue with any particular estimates or even the modeling approach, and it won't change things. And again, in my professional history, I've never, I have never, it is the most robust finding that I've worked on in my career. So I'm really very, very encouraged. The effectiveness data are just extremely compelling.
That's remarkable.
Yeah. So very often you say, well, this intervention is cost effective, but there are these caveats, and with this subgroup of people, it might not be, and the price of the drug has to come down a little bit, and then it'll be cost effective. None of that applies here. It's not like that. And I suspect that the intervention will get cheaper because we have in the intervention in the MAPS trials, which I costed, the regimen that we used in those trials, you have two highly trained therapists for 8 hours on each of the active MDMA days, but also two highly trained therapists for the 3 introductory sessions or pre-sessions before the active session and the integration session. So it's really expensive. And the conversation is, do you need to do that? Do you need 2 MD/PhD level practitioners, or could one of them be an intern or a more junior person? Could the integration sessions afterwards, could they be in a group context instead of individual? And so on. There are various ways you could think about lowering the cost without seriously affecting the effectiveness. Yeah, or maybe it's more effective to do group therapy. We don't know. There's so much to explore still. This is the beginning. Yeah.
That's fascinating. It means that actually the result could be even more remarkable than what you found out because the cost might be lower.
I think that's right. I think the potential to lower the cost is quite significant, and we should do the trials. We should find out.
Absolutely.
Yeah.
And also, let me ask you, in case in the audience there are people that would like to learn more about the kind of study and research that you've done, this cost effective analysis. What's your advice? Like, what kind of university or what kind of studies lead to this kind of consulting work?
Yeah. So again, in the U.S., I have a master's in public policy and then a doctorate in health policy, and I took lots of econ courses. I didn't know that I wanted to be a health economist. I just kind of followed my nose and I did what was interesting. And then, as I said, I met Jim Kahn, and he is the one who sort of got me excited about cost effectiveness analysis. So, but I guess to answer your question, for a young person, take classes in biostatistics, take microecon courses, health policy courses, health finance, health systems, so introduction to healthcare systems. We have courses like that in America because our system is so complex. You might not need them in Europe, but yeah, and yeah. I mean, there's a huge demand for cost effectiveness analysis now. I mean, in the old days, it was enough to show that something was effective, and now it's like, yeah, so what? It's effective, but is it cost effective? Is it good use for the money? That's the world that we're in now. Yeah.
Well, Elliott, thank you so much for your time. It was very interesting to speak with you. I will take the chance to have another proper look at the study.
Okay.
And I hope to speak with you again soon in the future.
Very good, Jonas. It's been a pleasure. I've really enjoyed it. So thank you.
Have a good day. Bye-bye.
All right. Bye-bye for now.